Hello guys, this is Dr. Asif. So welcome to my channel. So today we are going to discuss about the short case. As you know, in my channel there are several topics regarding this kind of lectures, that long case, surgical specimen, and imaging, or this kind of things. So as the continuations of the Viva exam, you will face as important segment, that is a short case, and most of the students are going to fail in this uh, in these segments, I think, because short case has a limited time, so you have to examine the patient and explain to your professors, and also you have to give some question answer session. So in all three term must be completed within 5 to 7 minutes, because in the exam you have to complete 3 or 4 short cases within 30 minutes. So I think it's a bit challenging, and a short case is like an instant diagnosis. So you will see the patient and make an impression or planning how to complete the sessions, then just go through according to your plan. So let's start with a very common topic, that is an ulcer. Okay, firstly, you must make a greetings or a patient doctor communications, like Assalamu alaikum, as I'm a Muslim, so it's my greeting policy. I'm Dr. Asif Nawaz, FCPS or MCPS examinee, or post graduation examinee. I will discuss with you about your disease and I will examine you, and you will not be get hurt. Okay, not get hurt. Sir, I need screening and attendant. So you need a screening and proper attendant, and ensure sanitizations of your hand and proper exposure of the patient to your position. Now some questions you need to ask. Yes, one thing I will mention, that you are not allowed to ask a, a lot of questions. You can go through 3 or 4 questions as usual, but not more, because it is not a long case. So what is your problem? How many days you are suffering from? What is the mode of the development of your disease? Either it is spontaneous or gradually after any trauma. Is it painful or not? Is it painful or not? Is there any change in size or color? Any size or color? Is there any evidence of change or not? Is there any discharge? Do you have any history of diabetes or problem sensation on lower limb, or take any medications? It seems that there is a lot of questions, but in short, in your exam settings, you will perform a quick question like problem: how many days? Is it painful? Any discharge or any color change? Or is it there any diabetes and sensations? That is all. Okay. Now, what you see here, you can see there is a raw ulcer in the dorsal aspect of the foot. Okay. So, I will start my examination by inspection, like side shape. This is the dorsal aspect. Size is about 5 into 6 centimeters. Uh, shape you can see regular, oval in shape, I think, and single in number. And age, that means here, this is the age. So age are the area between the margin and the floor of the ulcer, like it is a sloping edge. And this floor exposed surface within the ulcer. So what you are seeing here is the floor of the ulcer. Presence of granulation tissue, and some parts of the show necrotic materials. So what is granulation tissue? The red area. So these are the red newly formed tissues. These are the granulation tissues, and you can see some blacking and yellowish colored area. These are the necrosis. Okay, or necrotic part. So discharge, small amount of serous discharge, are because as it is raw exposed, so some amount of discharge we can found here. And the surrounding skin conditions are quite a bit longer, normal. So there is no scar mark, no engorgement, no pigmentations. But I can see there are some pigmentation surrounding areas due to lack of blood supply, or due to gross fibrosis. There is no change on the nail bed. And there is a normal hair distribution. As you know, there is a lack of hair in here because most of the hairy area is washed out. Okay. Now, in the palpations. So, as you have seen this ulcer, now you will have palpations. So, palpation means temperature surrounding skin and tenderness. Is it tender or not? Then base on which the ulcer rests. It is better to felt than seen. That means you will engage with your finger in the floor of the ulcer and try to move it. Okay. So, where the ulcer set out, that is the basement membrane. So the ulcer may be involved in the basement membrane or it may be lie above it. So how can you know? Not by seeing but feeling. Okay. So then examine the regional lymph node. You must mention, I will check the regional lymph node. And some of your professors will say, please perform lymph node examinations. So you will give in that side inguinal region, it is T-shaped. So inguinal lymph node will lie above T-shaped. Okay, so you will palpate these areas, and you have to check the neurovascular status. That means the peripheral pulses. And if any ulcer lies above any joint, then you will make a joint movement. Okay, so examine superficial inguinal lymph node are divided into oblique set. I have already stated that T minutes parallel to inguinal region and the longitudinal set of the femoral vessels. Okay, lie the longitudinal and the parallel to the inguinal ligament. Now that is all about the examination. Then you have to present your case in front of your teachers within 1 to 2 minutes. Like, there is an ulcer on the dorsum of the right foot, measuring near about 5 to 6 centimeter, which is irregular in shape, sloping edge. Floor is covered by granulation tissue and some necrotic materials, but no discharge from the surface. Surrounding skin condition is normal, temperature is normal, ulcer is non-tender, base is not indurated and free from underlying muscles. There is no regional lymph adenopathy, and neurovascular status is normal, and opposite limb and movement of the joint appears normal. So my diagnosis is healing ulcer on the dorsum of the right foot. Here I have mentioned the opposite limb. You can see here the opposite limb. So when any disease present on unilateral aspect of the limb, in that case you have to examine or see to the other limb as it is normal or not. Okay, this is the part of the examinations. Now there are some key and question answer sessions about what are the smooth and very available questions, like what are the features of different ulcer. So you can see this is the sloping edge or healing ulcer. So there are another ulcer, those are non-healing or infected or non-specific. So you have to know about all the ulcers as a basic. Like traumatic ulcer, anywhere can be happen. Venous ulcer above the medial malleolus because it is a bony area. So if normally venous ulcer happen here because venous ulcer is very common in case of varicose vein when it is ruptured, and small saphenous vein and great saphenous vein, especially great saphenous vein, lies in the medial malleolus. So more tortuosity can be seen just beneath the tibia or medial malleolus. So arterial ulcer, tip of the toe and finger, because it is a tip of the where the arteriole is finished and capillary started and also the venules started. So tip of the toe and finger is the check due to in case of arterial ulcer. The neuropathic or perforating or tropic, heel to the foot, pressure points of the foot. There's a neuropathic, like in the diabetic foot, like in the bed sore or pressure related necrosis. Tubercular, like neck, axilla. Okay, there is a ulcer which is formed from the cold abscess, or when the cold abscess ruptured, there is a flask shaped non-healing ulcer. And sometimes tuberculosis or microatrial tuberculosis is found within the discharge of the ulcer. Now, syphilitic means external genital and mouth. Rodent ulcer, it is also called the basal cell carcinoma, upper part of the face here, above the line joining the angle of the mouth to the ear lobule. If I make an imaginary line here, so ulcer may be found here. Also, the unilateral portion of the forehead, we have seen some cases, it is also basal cell carcinoma. Another aggressive tumor is ulcer, maybe melanoma. So melanoma can be happening anywhere, in the female lower leg and in male in front and back of the trunk, and palm and sole can be seen by a mole or black areas. Now, shape. Healing ulcer are regular. Tubercular ulcer are oval but may give an irregular crescentic border. Syphilitic circular or semicircular but may unite to form a serpiginous ulcer. And venous vertically oval. And the number. Malignant ulcer are irregular, and tuberculous and gummatous ulcer, various ulcer, varicose ulcer, that is venous ulcer. Soft chancre may be more than one in number. Sometimes malignant ulcer, tubercular ulcer, and gummatous ulcer and varicose ulcer are present, not single but multiple one. Now, the age. So, tubercular age are undermining and syphilitic and tropic age are punched out. You have to memorize and must know things, because during exam your teacher will give you a pen and paper and try to ask you, please draw a tubercular ulcer or traumatic ulcer or rodent ulcer. You must know the patterns. Okay. And the rodent ulcer raised and rolled, and squamous cell carcinoma raised and inverted. And surface and discharge, the syphilitic ulcer wash. In case of surface or discharge, you can classify in different things, like syphilitic ulcer wash leather slot on the floor. And in case of tubercular ulcer, apple jelly like appearance of the granulous tissue and scanty watery discharge. And in case of actinomycotic ulcer, sulfur granules. And the spreading and inflamed ulcer, purulent discharge. In case of infected ulcers, you can see pus or purulent discharge. In case of malignant tissue, you will see blood or black spot on the floor and easy bleed to touch, and there is a raw blood or bloody ulcer. Okay. And in actinomycotic, sulfur granular, yellowish sulfur granules. Okay. Now, another classification is pathological classifications. So it can be divided in non-specific ulcer, specific and malignant. So non-specific means mechanical or traumatic ulcer, tropic or nutritional ulcer, infective wound, arterial Burgess disease, and venous ulcer, varicose vein, neuropathic or neurogenic bed sore. And specific ulcer, tuberculosis, syphilitic, leprosy, and the actinomycosis, because these ulcer causative organism has their causative organism. And then malignant ulcer are the rodent ulcer, squamous cell carcinoma, and the malignant melanoma. Okay, sorry for the inconvenience. Now, how will you proceed? So, after thorough evaluation and proper counseling about the disease, I will advise some investigations for further management, because I have to ensure the ulcer is benign or it is malignant. Okay, so what investigation you suggest? The choice of investigation depends on your case, like discharge for culture and sensitivity, incisional and excisional biopsy, suspect if I suspect it is a malignancy in that case, local X-ray due to exclude the bony involvement, and definitely from regional lymph node for staging and malignant ulcer, because regional lymph node positive means the case is advanced. So what are the treatment options? The treatment option depends on the type of ulcer. Okay. So principal ulcer management. Determine the etiology of the history, examination and investigation. Then accurate assessment of the ulcer. Counsel the patient about the disease and further management. Identify and control comorbid factors and treat the underlying cause. Treatment of the ulcer by adequate deslogging. Proper broad spectrum antibiotics according to culture and sensitivity. Proper dressing of an ulcer. Some ulcer need specific management and multidisciplinary team approach and regular follow-up of the patient. So what do we see? These are the common ulcer management. Okay, and the criteria of an ideal surgical dressing. So in case of ulcer management, dressing is one of the important part, because you have to make sterile dressing each and every day or alternative day. So you must know what are the ideal criteria of a sterile dressing. So be absorbent. Your dressing should be absorbent, able to remove excess exudate, maintain a moist environment, and aid tissues to remove necrotic materials and promote healing. Prevent trauma to underlying healing, granulation tissues, and execute foreign particles from the wound. Prevent trauma. And be leak proof. Okay? And prevent strike through passage of organism through the soap dressing, causing secondary infection. Maintain temperature and gaseous extent. So your dressing should not be soaked out, because if that is so, in that case external air or bacteria can be go towards the ulcer through your dressing. So your dressing should be changed accordingly. Allow easy, pain-free, simple dressing change with less frequent application and removal. So be odorless, okay, cosmetically acceptable and comfortable, and be inexpensive, because it must be done repeatedly. That's why you need to know it should be inexpensive. So I think you have to go through it with some limited time, but you must know these criteria, because sometimes it is been asked in the exam. Okay, what are the causes of delay healing of the ulcer? What are the causes of delay healing? How can you know? There are some factors: local factor and patient factor. Local factors including infection, overbone prominence, malignancy, excessive movement of the ulcer area, and the sensory loss. That means these are the local factors. And the patient factor: old age, radiation exposed, poor nutritional status, neurological deficit, chronic disease, and chemotherapy taken patient. Now, the very common in our country or in all of the world is diabetic foot ulcer. If it's a healing ulcer, but the patient have diabetes, so this is another term, just as same, but there are some limited things which should be changed during the presentation. Three etiological components are responsible for diabetic ulcer. Okay, so impairment of peripheral circulation leading to local ischemia, atherosclerosis. A diabetic patient are more prone to it in an early age. Microvascular disease also. Impairment of sensations due to the peripheral neuropathy, and poor resistance of the tissues to trauma and infection owing to the presence of the sugar in the tissue, and that's why more bacteria is accumulated due to the increased sugar. Characteristics of ulcer is the same in the tropical ulcers. Character neurogenic, should be infected with ischemia. So atherosclerosis is much more associated with the diabetic foot ulcer. Investigation should be same, like discharge for CS, RBS, repeated CBC, complete blood count, HbA1c to know the 3 months glycemic status, and duplex study to see the condition of the vessel wall, because there is some microvascular complications. So you should know there is any atherosclerosis, or how it is progressed or not. It should be detected, and the local X-ray to see any bony involvement. Now, treatment should be done by multidisciplinary team approach. So, medical management, the aggressive glycemic control of comorbidities, then restricted weight bearing, control of the life-threatening limb infection. So, surgical management should be debridement and regular dressing. In complicated cases, distal revascularization technique, endovascular or distal bypass, and amputation. So, these are the treatment protocol. Okay. Okay, that is all about the ulcer, because you have very limited time Like if I calculate for a single uh, short case, so you will get 5 to 7 minutes for a whole short case. Thank you very much for watching my videos, and I think you will like and subscribe and keep continue to support me. That will give much more encouragement in future. Thank you very much.